Thanks so much for inviting me to this special occasion. I'm going to talk for just a few minutes about interventional radiology and the treatment of uterine sarcoma, and some of this is going to apply to other sarcomas as well. So we'll talk a little bit about surgery versus ablation, because basically everything we know about local regional therapy and interventional radiology comes from what we learned from surgery. Different types of ablations, some post-ablation findings, and even some complications. So here's probably one of the most important slides that directs us in interventional. This is a slide from a pretty cool group of people here at Sloan Kettering that looked at liver mets from sarcoma and just stratified according to whether the patients actually underwent a liver resection to eradicate those mets or if they were unresectable. You can clearly see that for sarcoma patients with liver mets, patients who underwent liver resection survived longer than those that did not. This was even more true for lung mets from sarcoma, and you can see that the resection status made a big difference. If you were able to completely resect the lung metastasis, those patients did the best compared to those who had incomplete resection or no resection at all. So again, like the liver for sarcoma patients with lung metastasis, those who undergo complete resection survive longer than those that do not. This was looked at pretty extensively, and besides resection status, the age, the grade, and the disease-free interval, really getting at the pace of disease, tells us a lot about who's going to do well after a metastatectomy from a sarcoma. And moreover, once these lesions are resected, if the lesions come back again and they're re-resected, the patients continue to do well and continue to follow that better curve than those that have a repeat incomplete resection. So if you're going to do a local regional therapy as a metastatectomy, you want to have a complete resection. If we look at another group of resection patients, in this case colorectal, and this was really, I think, pretty landmark work. It's one of the most highly cited papers out of Sloan Kettering altogether, that looked at a very large cohort looking at the multivariate predictors of recurrence following metastatectomy for colorectal metastasis to liver. What they found out was the most important factors were margin status, the presence of extrahepatic disease, and other factors relating to biology of disease. And if patients had 1 to 3 tumors, those patients did better than patients who had an attempted resection of 4 or greater tumors. So if you can achieve a complete negative margin of a small number of small tumors, these are the patients who are going to do best. So this is really what we learned from the surgeons. Good biology disease and a good ability to get a good margin will lead to the best metastatectomies. So what are indeed these, and the ability to do a complete resection. What are those interventional radiology alternatives to resection of metastases? Well, we have a few different techniques that are on our smorgasbord here. Radiofrequency ablation, cryoablation, microwave ablation, irreversible electroporation, and percutaneous ethanol ablation. I'm going to talk a little bit about most of these. So radiofrequency ablation, turning electricity into heat. This is basically very similar to cautery. You apply electrical energy via what we call an antenna or a probe at the site of the tumor. The generator generates electricity, and you complete the circuit using grounding pads. This heat, this frictional heat that's caused by the circuit, denatures proteins at the temperatures of around 60 to 100 degrees and can cause an area of ablation of about 1 to 3 centimeters. Microwave ablation is just the same version, a very similar version of the same thing, except here we're turning microwave energy into heat. And in this case, unlike radiofrequency ablation requires a complete circuit, the microwave antenna actually emits radiation and causes water within the tissues to boil. This heat denatures the proteins, and because it's radiated, it leads to a very bigger heat change and an even larger area of ablation. The patients don't need grounding pads because it's not based on a circuit. And because the energy is radiated and not conducted, there's less of what we call the heat sink effect, this variability within the density and within the pathologic makeup of tissue that some parts of the tissue will absorb more energy and some parts will absorb less. If you think about it, any heat-based technique is basically doing this. It's heating the tissue, it's dehydrating it, it's desiccating it, and it's denaturing proteins. And here's a pathologic specimen from a RFA case, and you can see that it looks very, very similar. So it doesn't matter which heat-based technique you choose, you're basically rendering tissues non-functional by causing denatured proteins. Cryoablation looks at the opposite effect, killing tissue by cooling it, and it really takes advantage of the Joule-Thomson effect, whereby an expanding gas can cool. We all know this effect. You take an aerosol can and you spray it, the can is going to get cold as the gases expand. This was actually a diagram from the first patent on a cryoablation needle, where gases travel through the inside of a hollow needle and expand at the end of the needle, causing cooling at the tip, and the gases then are vented out. In this case, we typically use argon gas as the coolant. The cryoprobe's inserted into the tumor, and the argon gas cools. It cools to a very low temperature, 150 to a negative 180 degrees. And what happens is you get the formation of intracellular ice crystals, which disrupt cell membranes. And one of the great things about cryoablation is as the tissue freezes, it becomes a little bit less dense than the surrounding tissue, so you can see it readily via a CAT scan. If we look a little bit more at this freezing process, as you start to freeze a tissue, first you form extracellular ice, but that doesn't really cause any long-term tissue damage. But as the extracellular ice continues to form, there's dehydration of the extracellular space, drawing water out of the intracellular space. As the intracellular space starts to freeze, we form intracellular ice crystals, which causes pores in the cell membrane and basically causes these cells to not function anymore. At the same time, the formation of intravascular ice causes ischemia within the tissues. So the main harbinger of cell death with cryoablation is the formation of intracellular ice crystals. And anything that we can do to make that happen more is going to make the cryoablation more effective. In this case, having a colder target temperature, having a faster time to target temperature, a longer time at that target temperature, or repeating these cycles with freeze, thaw, freeze, and thaw. One of the new kids on the block in interventional radiology is irreversible electroporation. You might be familiar from your laboratory days of reversible electroporation, where applying electric field to cells causes small pores in the cells that allow you to put plasmids or other biologics into a cell. Irreversible electroporation uses a different electrical pulse, which causes irreversible pore formation within cells. And so these strong electric fields permanently permeabilize the cell membrane. Right now, with our technology, it's a very small area that we can create this irreversible electroporation, usually 1 to 2 centimeters. And also, because of these very strong electric fields and currents, the patients have to be under general anesthesia and have to be paralyzed. It's relatively technically difficult because the probe, in order to generate that electric field gradient, the probes have to be placed perfectly parallel to each other. What's good about electroporation is this. When you place these probes and you create the electric field, you will get permeabilization of the membranes, but the stromal tissue in between, the fibrous tissue, because it's not cellular, it isn't damaged. So basement membranes and fibrous tissue does not get damaged with irreversible electroporation. This minimizes the risk of perforation or leak within the kidney, at the collecting system, or even at the bowel. How effective is image-guided ablation for liver metastasis? Well, this was looked at recently in a meta-analysis. You can actually see, and I won't go through this whole thing, but the overall odds ratio was in the range of 0.7, showing a favoring surgical resection. Surgical resection definitely had an overall survival improvement compared to radiofrequency ablation. However, in the same analysis, when they looked at complications, what they found was the complication rate was a lot lower. So at least for colorectal metastasis, surgical resection had an 11-month increase in overall survival, but carried a 3 times greater complication rate. Who are the ideal candidates for thermal ablation of metastasis? Well, it really has to do with balancing the high efficacy of surgery, which we absolutely know, against the low morbidity of ablation, and finding the right patients where this is a good combination. So certainly patients who are not a good surgical candidate, either due to coronary artery disease, COPD, or poor ECOG status. And patients who have good biology of disease, as described by the factors that we already know about. Good tumor markers, long disease-free interval, minimal extrahepatic disease, and only a few tumors. Also, we need to have good technical factors for ablation because obtaining a complete ablation is what's going to lead to good overall survival. This issue of margin has been looked at pretty extensively by our group. And we looked at patients who had colorectal metastasis who had increasing size of margin, and we compared that to local tumor progression rate. And you can see that when the margin is very slight, 1 to 5 millimeters, we have, it's 50-50 whether the person is going to have a recurrence. But as those margins get bigger, it gets safer and safer. And you can just see the kind of broad stratification of these Kaplan-Meier curves for different margin sizes. So a greater than 1 centimeter margin provides the lowest rate of local tumor progression after a liver ablation, and this is very concordant with what they see in the surgical literature. So let's look at a few cases, specifically of uterine leiomyosarcoma. Here's a 50-year-old with uterine leiomyosarcoma, has one solitary, after a few years of active surveillance, had one solitary lesion. It's in a really tough spot here in the right middle lobe. It's been between two pulmonary arteries. This central nodule would probably require a lobectomy. We performed radiofrequency ablation in this case under CT guidance. We placed the needle pretty carefully into the spot, into the center of the lesion, and we ablate it. Notice that there's sort of a rim of edema around this nodule, giving us an idea about where the margin is. So this just illustrates how very precisely, with all the great tools that they have in the Center for Image-Guided Intervention on M2, how we can target these lesions and try to really use a smart bomb approach to try to get rid of them. If we look at this same lesion over time, 1 month after the procedure, we're starting to see this some implosion. It's starting to cavitate a little bit, and as time goes on, it forms a stable scar that by 18 months is almost imperceptible. Now, this brings up another point of, so ablated tumor scar over months to years. This same patient had a good disease-free interval for another 2 years, but developed another nodule, this time in the left lung. We performed this, actually this time she got microwave ablation, and you can see again kind of a halo, we call this a ground glass halo around the nodule, showing us where the margin is. And over time, again, we see that scar formation eventually turning into a very slight scar. So new nodules can be treated as they appear. If one or two nodules show up, that again speaks to this kind of like low-grade leiomyosarcoma. But if 8 nodules appear, we're probably not going to be able to treat that. In fact, nobody's going to be able to treat that very effectively using a local regional approach. Here's another case, a 40-year-old with uterine leiomyosarcoma, a solitary lung nodule. This is actually, it's growing. It's in okay proximity to the aorta. We brought this patient for ablation, and on the morning of the procedure, which is about a month after this, you can see it's now abutting the aorta. So this is making it very difficult. Which modality are we going to choose in this case? In this case, we decided to go with cryoablation. In this case, we put a cryo needle into the lesion, and then as we froze it, we're able to apply traction to the lesion to actually pull it off the aorta, and then perform the remainder of the ablation. Now note how the ablation site is slightly lower in density than the muscle that's next to it. That's because that's showing us exactly where the ice ball is, and we've got a nice margin around the lesion. 3 months later, you can tell that this not only is shrinking, but it's no longer enhancing. So we use cryoablation for treatments where we need very, very rigid control over the treatment margin to make sure we're not going to injure any critical structures. Finally, I'll just show one other case of a liver metastasis. Here's a 40-year-old with uterine leiomyosarcoma. It's metastatic to the liver. 2 months later, this tumor has more than doubled in size. So this is an aggressive lesion, and we're certainly worried about this lesion. In this case, we're looking for a modality that's going to kind of aggressively control the margin. So what we did in this case is we first embolized the tumor. That is, we went in through the groin into the blood vessels of the liver and basically plugged up the blood vessels that feed that part of the liver so that we get a kind of double kill effect. We can start by making the tumor ischemic and then applying a heat-based technique, in this case, microwave ablation. And what we get after that is you can see, it's quite a bit larger margin than you would get from microwave ablation alone. And a few months later, we continue to see a shrinkage of this ablation site, and 12 months later, it continues to shrink even more. So embolization plus ablation provides a double kill effect, which can create a wider margin and less recurrence. So just a few thoughts about interventional radiology and uterine sarcoma. Ablation is a low morbidity alternative to surgical resection. Surgical resection has the best overall survival, and if a patient is a surgical candidate, we want them to go to surgery. But if they're not, or if they have other reasons why we want to minimize their morbidity after the procedure, ablation is a good option. And patient selection is the most critical function. So we're looking for a good biology of disease, and we're looking for a margin which will be, an effective margin, because it's the most important factor in predicting recurrence. So this is where I really enjoy working with the gyn-onc group, because we have a great, ability to sort of discuss the cases, get an idea if we're going to be able to get a good margin, talk about alternative therapies, talk about surgery for this nodule and radiation for this nodule. And but I think sarcoma is a great place to apply interventional radiology techniques. Thank you.